Greetings and welcome to In-Depth. I'm Dike Rostant. Now, hip osteoarthritis is a painful degenerative disease of the hip joint. It develops over time through wear and tear, and it can lead to a situation of bone rubbing on bone. Now, Dr. Stefan J. Coombs is an orthopedic surgeon. He joins us to discuss advancement in hip replacement surgery. Dr. Coombs, how are you doing, sir?
I am great, thank you. How are you?
I'm all right, thank you. But I'm always interested in finding out how people are where they're finally at or where they're at this point in time. I'm not sure if anybody gets up and say, hey, I want to deal with hips and replace it from primary school. So give us some signposts along that journey to where you are now, thanks.
Okay. You're right. I didn't get up in primary school one day and decide this. However, I would say, so some background, I'm from Trinidad. I'm from San Fernando in particular. I went to Pres Sando, and I think it started just with a love of science, going into primary, into secondary school. I was very interested in biology, human biology as well. And having a background of both my father and my brother being in medicine, I think that to some extent I gravitated towards it. Interestingly enough, I actually at some point tried to rebel and tried to do biomedical engineering, or I once wanted to be an orthodontist, but for some reason I just kept coming back to medicine. So the sciences, in addition to just honestly just loving to interact with people and build relationships, I think that's what drew me towards medicine on a whole. And then, so I went to medical school at the University of the West Indies in Mona. And after that, I returned home to serve the country in the government sector for 4.5 to 5 years. And that's when I made the decision that I wanted to do something surgical, because I am motivated and I gravitated towards procedural work, in the sense that you can do a procedure and after that procedure, have some sort of lifelong impact on a patient and help them in that way. And orthopedics was just a perfect fit for me when it comes to that. It's just the tangible kind of results that you can get in terms of getting a patient back and moving or walking that really interested me. And that's when I decided, well, this is it. I'm going to embark on this journey.
Do you get the opportunity to interact in passing, possibly post-op work, aftercare, with persons that you have impacted in this sort of way?
Yes, actually. So I did my orthopedic training in Washington, D.C. at Howard University Hospital. And it's funny that you say that, because after, let's say, trauma cases, where patient may have fractured their tibia or something, I remember one specific patient, literally, he saw me probably about 6 months later, and he's like, "Hey, doc." And I saw him up and moving and without a limp, very mobile and functional. And he greeted me and told me he was doing well. So yeah, that definitely is the opportunity. And then follow up, right? So in the office, specifically in my subspecialty, joint replacement surgery, we tend to see patients back in after surgery a few months, and then we do like a yearly anniversary of seeing patients. As long as you're doing really well, then we see you back every, let's say, 5 years or so. So there's good follow-up to see how patients are doing, and also just see the impact you've had on them.
And I asked the question because of you saying how gratifying it is to feel that you're making that difference. But I feel that possibly you didn't run as far as you may have thought that you did, because in terms of like biomedical engineering is one thing, but looking at advancements in joint replacement surgery, I think one of the things that you also do is working using technology like robotics to help you do what you do. So take me through that process, thank you. And in the sense that what would have obtained previously to what it is you're using now, and possibly how it is you help to merge those two.
Okay, good. I like, so the question of what I was doing previously and what I'm doing now is interesting. So in my residency, so not every hospital in the world or the US or North America has the type of technology that we're talking about. So we're talking about using advanced type of robotics and navigation to help with the surgery, for lack of a better way of saying, enhancing your accuracy in performing the surgery. Because in all of these surgeries, we kind of prepare the arthritic joint to be able to take an implant, and if you perfectly align those implants within degrees, within millimeters, you can get the best outcome. Right? So the traditional ways of doing joint replacement surgery is certainly tried and true, and it's still being used in the majority of the world with excellent outcomes, right? I think the technology is kind of pushing the envelope to try to get even better at what we're doing. So we're trying to get from a 95% satisfaction rate to 99% satisfaction rate. And that's where I see the future heading. I would say in my training in residency, I had very little exposure to the robots, right? We did some robotic work and in training, but we call it the manual standard way of doing these procedures. A lot of it was based off of that. Now, when I moved here to New York to subspecialize in joint replacement surgery is when I was introduced to everything basically. So every type of robot and almost every type of navigation tool that can be available was available. And that's where the training and the learning curve and everything starts. And I mean, to the point now where it's like second nature, you know? But I would say though that the even though you're using a robot, you still need to, nothing is perfect, right? So having the background training of doing manual work helps in the sense that if things were to not add up in terms of your knowledge of the anatomy and what you think is right, which is honestly not very often, but you still need to have those skills to be able to do that as well, to be able to troubleshoot and to be able to override the robots and what they're saying.
Totally get that. And then sometimes I use the analogy of someone having a fast car, but they don't have gas or they don't know what to do with it. So it's problematic. That and someone walking is basically the same thing. But in terms of and we didn't necessarily get into reasons that would lead to degenerative disease. So are there factors that may help or help to mitigate this type of degenerative disease dealing with, and if we're looking at joints generally, possibly hips specifically?
Okay. Yeah, certainly. I think they're modifiable and they're non-modifiable risk factors, right? Genetics plays some degree of a role. So those, we can't necessarily modify our genetics yet. But when it comes to the modifiable risk factors, one, safety, just not getting injured, right? So traumatic causes is one reason to develop osteoarthritis of the hip. So, I mean, I'm not one to tell people that they should not perform, extreme sports and things that can get you injured in that way, but that's definitely a risk factor in terms of it. Another risk factor that's been proven in the literature has been obesity, right? So there's a study saying that for every certain amount of pounds that you lose, 10 pounds that you lose, you decrease the joint reactive forces on the joint by up to about four times, right? So interestingly, we've had patients come in with painful degenerative, both hip and knee osteoarthritis. And to kind of mitigate complications, we actually tell them we should get on a weight loss program, right? And this is to decrease the chances of wound healing complications, decrease the chances of infection, stuff like that. And so the patient goes, they lose 30 pounds, and then they say, but doc, my hip doesn't hurt near as much anymore, right? I think I could do with physical therapy and some anti-inflammatories, and we should be fine for now. And that's still a win, right? because honestly, surgery is a last resort in these treatment modalities. So those are some modifiable. And then there are other causes of arthritis. We're talking about osteoarthritis, but you also have rheumatoid arthritis, right? And psoriatic arthritis. There's different inflammatory diseases that can cause arthritis of the joint. And that is the best treatment for that would be, one, being diagnosed early, and then two, getting started on medication to prevent destructive disease of the joint.
And with that, we take a short break and return. We're actually speaking about advancements in hip replacement surgery. We're doing so with Dr. Stefan Coombs, Stefan Coombs. So stay with us. We return with more. Welcome back. We are speaking with Dr. Coombs, one of three, apparently, advancements in hip replacement surgery. And I like the fact that you spoke, Dr. Coombs, about alternative methods of dealing, possibly lifestyle changes, losing that weight. I remember that I won't say swore off, but I started leaving nicotine alone when someone said, that makes it harder for bone regeneration. I said, say less. So sometimes it's just, mommy say a word to the wise is sufficient. But I'm also wondering, though, who are some of the other partner stakeholders that you would have? The way that you would speak about someone you having physical therapy, is occupational therapist part of the package, and this is both before and after, because I can imagine someone in terms of looking at how it is the walk being an issue, and even if you have something like one leg being a little longer than the other, because you spoke about very small gradations can possibly making a difference. So who are some of the persons that you work with, possibly not orthopedic surgeons as well?
Yes, definitely. So I love the fact that you pointed that out, because this is really a multidisciplinary approach to providing excellent patient care, right? And it's a team effort, and the surgeon is I don't want to say useless, but the surgeon is, the effectiveness of providing that type of care is significantly amplified by having a good solid team of, and I'm going to mention these stakeholders, as you call them, physical therapists as one, right? But let's not also forget the nurses in the operating room. So you have circulating nurses, you have scrub nurses, you have people that help to ensure safety for the patient. But then in addition to that, they help to run a smooth day, make sure all the instruments that we need are appropriately sterile and the counts are correct and everything. In addition to that, other physicians who play a role would be the anesthesiologists. And because we're talking about advancements in hip replacements or joint replacement surgery, that we tend to lose sight of how integral of a role the anesthesiologist plays in the efficiency, the safety, and the effectiveness that is carried out, because there have been changes in terms of how they deliver anesthesia to help this process be a smooth process with less blood loss, with less complications as well. So instead of going under general anesthesia, the anesthesiologists have now started, more often than not, almost standard of care, using spinal anesthesia. So essentially the patient's sedated, but they have spinal anesthesia that prevents them from feeling any painful stimuli below a certain level. And what that also does is that has in the studies have been shown to decrease blood loss, decrease complications such as clots as well, right? And also decrease morbidity and mortality. So they play a huge role in terms of helping us to provide this surgery safely. And then there's also a medication called tranexamic acid, which has been shown to decrease blood loss significantly as well. Now, so that's during surgery. After surgery now, the people that help play a role would be the nurses on the floor, in addition to physical therapy, as mentioned. And in addition to that, social workers, right? So patients don't go home and they're fully and entirely independent. They need the social workers to help set up stuff such as raised toilet seats, depending on the approach that you use, and a visiting nurse and a health aide. If we need antibiotics for different types of operations, they help set up infusions and stuff like that. So you're right, it really is a multidisciplinary approach. And sorry to go out of order, but preoperatively, you also have patients who, you also have physicians who help to optimize our patients. So they try to get the patients on the correct medications to control their comorbidities, such as diabetes, high blood pressure, help to their weight loss programs as well. So it really is a multidisciplinary approach, and every player plays a significant role in it.
And looking at the different factors that go into some of these advancements, you spoke about the technology, yes, in terms of robots, but grounding it in the need for a solid base that you can always rely on, especially since not everyone has those technological advancements that would be available to others. But one of those advancements may be materials that you would actually use for the replacement joints. Give me a little idea about the timeline of how it is those materials have been used, sourced. Is it that this has a shelf life, so we need to replace it after this amount of time? What is that like from where you sit?
Definitely. So we're talking probably 2 decades or so, right? The transition of materials from about 2 decades ago until now has been drastic. And it's all been geared towards longevity, right? And outcomes. So we're talking about, okay, well, in 2007, the Lancet quoted this hip replacement surgery as the operation of the century. So that shows that we were doing great in 2007, right? However, we're trying to improve each year. And so let's talk about the actual materials. Right now, I would say in North America, standard of care is, or what is typically used, is a titanium type stem and a ceramic type head, right? Ceramic or metal, right? And then you have a liner, which is essentially to prevent friction, right? That's
what the cartilage would be.
Exactly, right? So the liner helps to prevent friction and to allow range of motion. And a lot of advancements and then you have the socket where the ball and socket joint is recreated. Now, what have the advancements been? The type of stem at this point now matches the stiffness of your bone so that there's a decreased incidence or chance of you having any type of thigh pain after surgery. All right. And then the other advancements, which this one has probably been one of the biggest, is the way that we process and manufacture the plastic. Because just like the good Lord made our joints to undergo some sort of to prevent damage with a cyclical motion of your joint, we also have, as you very well compared the plastic to the cartilage, the plastic could wear out, right? So what we've done now is the scientists and the engineers they've developed something called highly cross-linked polyethylene, which is an advancement in the plastic that now has been shown to have wear rates of almost negligible in terms of how long they can last. And right now, the jury's still out in terms of how long the plastic lasts because they've been doing so well. So we're now talking about 15 plus years, 15 to 20 years. But once again, a lot of this has to do with how perfectly these implants are put in as well, and a margin of error in terms of the degrees and the millimeters as well.
And speaking about that, the procedure of implanting, we spoke about materials, we spoke about using technology like robots, but has the process of putting it in changed? And I ask the question because do not ask me to cut a chicken for you, slice a turkey or whatever. There's some people, they know exactly where that socket is and it feels as though they just draw a line and it's soup and it just opens. Yep. Me, I am a butcher. So
Yeah.
I'm glad that we each sit where we do, but
Yeah.
the surgical technique, how has that
Mhm.
changed?
The surgical technique has also changed drastically. I would say before you would perform larger incisions, right? And at this point, we've gotten so good at doing these procedures, we as a field, that we're now doing minimally invasive kind of muscle sparing procedures. And what we've shown doing those procedures is a significant acceleration in rehabilitation. So we're getting patients up and moving and out of bed faster, right? I mean, there are a significant number of patients now that are leaving the day of surgery, right? So we just did surgery, a couple hours ago, and the patients at this point in time are probably about to go home,
You're talking about
right?
ambulating on their own power?
Ambulating on their own power. They're walking with physical therapy in the recovery room, and they're getting discharged from the recovery room, obviously safely, right? So you there's a kind of risk stratification that takes place where you look at the okay, what are the medical diseases? How does this patient need to stay overnight or for a couple of days to be monitored, right? What is the age of the patient? And then you also look at support at home, right? So who do you have at home? But all of those factors, once all of those, we kind of go through that checklist. Yeah, patients leave the day of surgery. And a lot of this has to do with, once again, anesthesia. I think they play a huge role in that process in terms of it's almost like an art of the sedation in addition to the spinal anesthesia as well, and what dose to give and how to kind of time things. But when as you mentioned, the procedure itself has changed, the different approaches that we can use to kind of get to the diseased joint has changed as well. Because before we used to only do procedures where we traumatize some muscle or some tendon, right? And now we're doing procedures such as, let's say, the anterior approach to the hip, where it's essentially a muscle sparing approach. You don't traumatize muscle or cut the tendon, you just kind of sneak in between muscles to get to the hip, and you can perform the entire procedure through an incision about this big. Yeah.
Now, we have just under a minute, but goals. So you've given us a lot of information of where we've come from, but looking to the future, what are some of the things that you see within that minute?
There's a lot to answer in a minute, but I'll try. In terms of goals, my goal ultimately, personally, is to get to my fullest potential. To use the I've been blessed, to be in a certain position, to have the education that I did and the family that I've had and the opportunities and the mentors as well, the teachers going back from primary school up until now. But I would say it's just to take it to another level as much as I can, while maintaining that the ultimate goal is to provide excellent patient care, right? I think we as surgeons do this every single day, but every time a patient comes into your office, they're having that procedure hopefully once in their entire lifetime. So that's going to be their only experience. So that's that. And then the other goal is I'm very interested in teaching and mentoring. So people that have wanted to do this, that were in my, let's say, a presman from in form 3 or form 4 that wants to do this, I am always fully available for someone to reach out to me, and I want to mentor people and teach them to bring everyone along the way such that we can advance in the field.
And I think it also speaks to the teachers that you have had that would have instilled that sense of responsibility as well to want to pass it on, to share that knowledge. But
Definitely.
definitely we want to thank you for the time. We want to thank you for the work that you're doing, and Dr. Stefan J. Coombs. And this has been In Depth with me, Dike Rostant, on behalf of the entire team at TTT. Thank you so much for joining us.